In the spirit of reconciliation, DHSV acknowledges the traditional custodians of the land that we are filming on and their connections to land, sea and community. We pay our respects to their elders past and present and extend that respect to all Aboriginal and Torres Strait Islander peoples today. Welcome to the DHSV Coffee Catch-Up series, where we shine a light on key oral health issues to spark discussions that lead to change. Today, we're talking about oral health research, which is crucial for advancing our understanding of oral diseases, developing innovative treatments, and promoting evidence-based practice. Research not only drives oral health advancements in technology and treatment, it helps address oral health disparities and promote health equity. Here to talk with me about all things oral health research is Professor Alastair Sloan, Professor of Tissue Engineering and Dental Biology and the current head of Melbourne Dental School. Alastair obtained his Bachelor of Science in Biomedical Sciences from the University of Wales and his PhD in Oral Biology and Pathology from the University of Birmingham. He went on to enjoy an illustrious career in the UK, which started with a lectureship in oral biology at the University of Birmingham and progressed to being appointed Dean of the School of Dentistry at Cardiff University. In 2020, Alastair relocated to Melbourne, which was lucky for us. As a researcher, Alastair has been awarded in excess of $10 million in external funding and published over 90 peer-reviewed papers. In 2022, he was awarded the Distinguished Science Award by the International Association for Dental Research. Thank you, Alastair, for joining me here on the couch today. It's so great to see you.
Pleasure.
So my first question, how can oral health research help reduce the inequities in care and in oral health?
That's a cracking starter for 10. I think oral health as a profession, and that's the key word, it's a profession.
Yeah.
So we're evidence-based.
Yeah.
And I say we as a bioscientist, I'm part of that bigger team.
Yeah.
But dentistry oral health professionals is a profession. We need evidence to make changes, to influence practice, to influence communication, healthcare promotion. And that comes from research that is undertaken either in dental schools or my preference is in dental schools, but with feelers in other areas of healthcare and allied healthcare.
Yeah.
Medicine being one of them.
Yeah.
But I certainly think schools of bioscience and biomedical sciences are another area. So what we do is actually, I think, from a research point of view, ask some of the very tricky questions.
Yeah.
What therapies do we need? What clinical modalities do we need? How do we influence and change current treatment practice?
Yeah.
That's at one end.
Yeah.
But also, how do we get out there to those patients that can't access care at the moment?
Yeah.
Because novel or different approaches might influence how we deliver that care.
Definitely. I think, we've been talking earlier today with some other people in relation to the siloed approach to healthcare that we currently have, and how do we actually shift some of that as we move forward, because it's not working, so we need to figure out a way to make it work. So on that point, how important are partnerships in actually building research and building the evidence base for good oral health care?
They're fundamental.
Yeah.
I think in the current 21st century, given the pressures we all have from a funding point of view, you can't do things in isolation or in silos. And you, hospitals, don't have all the answers. And when I've seen great success in any aspects of healthcare and health biomedical research, it's been partnerships. It's been a mix of hospitals, clinicians, basic scientists, public health scientists, nurses, end users, so patients, and the patient advocacy and the patient voice, they have to come together. Where I've come from in the UK, the trend for the last decade has been any biomedical research that's funded has to have impact.
Yeah.
Taxpayers fund my research. What's the impact of that research? Well, the impact for us is twofold. One, it could be a health economic change, or it could be a real patient outcome.
Yeah.
But to do that, you've got to have different members of a team, and that's everything from the clinician scientist, the hospitals, and I say the end point, which is the patient users. So in the current climate, we cannot make clear advances without a partnership and a collaborative approach to research.
Yeah. Where have you seen that work really well? Like, have you got examples? I mean, I know you've only been in Australia for 3 and a bit years, and for 2 and a bit of that you were in lockdown, so you couldn't do anything anyway. But, where have you seen that work really well, where you've actually brought the entire, community based around the work that you're doing to actually make a difference?
If I use an example from my old school in Cardiff University, there's been about an 8 or 9 year piece of work between a company that's out of Norway in Scandinavia, an oral surgeon that was dealing with lots of significant wounds and problems within the oral cavity, and microbiologists that had an understanding of actually how wounds may get infected. And this was taking a concept of a novel protein and a novel therapy and taking it from this small SME, this small little company that said, we've got this potential molecule coming from seaweed and we think it can do X.
Right.
And the first 2 or 3 years of that funding with that team in the dental school at Cardiff showed it could do X. But then it opened opportunity for colleagues in respiratory medicine and those dealing with cystic fibrosis who were also interested in this molecule because it had some different side effects that were very, very beneficial. So that project grew from a very small 2-year project to a 5, to an 8, and now, if I've been here 3.5 years, it's got to be a decade old. That has led to a new clinical product. It's now applied and being actually delivered with patients in a range of different clinical scenarios to improve their treatment. And that was a different way of thinking when it first started. It was, we've got to work with the company. That is now the norm in the US and in the UK, becoming more normal in Australia now, and we've got pockets of it, but it's not as widespread as I would like to see it happening. But what you'd had was people saying, well, I've got this, we've got this expertise, we know what we might want to do with it there, and every ego got parked outside the door, and there was one common goal. And that project with Dave Thomas in Cardiff has been hugely successful. That's just one of a number that I could mention, but it's one that's close to home because I worked alongside Dave and then I was his head of school when I took that job on in Cardiff.
So I was talking to Jane about clinical leadership and how they want to actually do some more work in that space at the University of Melbourne, which I think is really important because none of this can, nothing that we do in healthcare can be done without the clinicians and particularly that leadership group driving some of the behaviour change, but also driving some of that research and that translation into practice.
Absolutely, and I think MAC, so the Melbourne Academic Leadership area that John Saville's brought in, is making some good step changes in medicine. It's reaching out into other allied health professions now. It's small and nascent. It's based on the system that he developed in the UK with NIHR. I think it could work for oral health. I think it's incumbent probably for you and I to work out how it can work.
Yes.
Because if we want clinical leaders, I certainly feel they should be employed within the public health hospital setting, working in collaboration with the school or with the department in the school to drive forward the element of research and then translation back. Not as easy as it is in the UK, but I think the challenge probably for you and I'd like to think that as I come to the end of my first term as head of school is maybe trying to see how John can help us make it work. Because I think there are some very, very bright young clinicians out there and specialists that will actually want to get on board with this.
How do we build that enthusiasm within the undergraduate or postgraduate level for clinicians to look more broadly at a system rather than I'm focused on my part of the clinical piece that I'm looking at particularly?
Great question. And it's not easy because we do expose our DDS students, our BOH students to research, and our DCDs do a minor thesis. But that minor thesis has to be something that sparks an idea with them. One of the things we're looking at in the school is the DCD PhD route, which does take some investment from the school. But if you've got a cohort in perio or in pediatrics or in ortho or in endo, and one of them wants to do the DCD and a PhD, then that's the person you try and grow. Now to do that, you also want to have a sense of the breadth of that activity, and so seeing patients in the hospital, MDC, and their research project has to be relevant to their clinical interests and the challenge that we find. But I think once you get one or two, others will think, well, that looks like a good environment for me to be in. We have to grow small. But in a way, if we actually can get an appointment position where there can be a lot more conjoints between us and the hospital, and so it's not us and them, it's a we, this centre of excellence, which I think would be great. So the conjoint appointments are there, then actually we allow people to build their careers in a very supportive environment. And I think I see it in surgery, talking to Peter Chung. Graduates now, especially specialists coming through, don't want to do what colleagues of our generation did in private practice or in hospital practice. They want to mix.
Yeah.
When we were looking at recruiting last year for new demonstrators and clinical tutors, as I like to call them, we had 144 different people put their hat in the ring, all of which were pretty young grads. They want a mix of private, public, and hopefully research or teaching. Well, our job and our challenge is actually how to make that work.
Yeah.
Because I think the incentive and the drive from those graduates is there.
Yeah, I would agree. I think that the traditional route of you're either a clinician or a researcher or an academic, or you work in private practice or public, or you do half and half. I think people want a more well-rounded work life. They don't just want to do X, they want to do a variety of things. And I think the generations that are graduating now are much more interested in something that's more diverse rather than I just want to do X. And how do we, it's up to you and I to figure out how do we actually build those career pathways for our students, but also for our new graduates, or even our mid-tier, mid-level
without doubt.
clinicians.
And they're very different.
Yeah. Absolutely.
We want to hire a new convener, maybe, as and when people change and move on. So a convener of, let's say, one of our postgraduate programs, does it have to be one person on a 0.5 or a 0.6 position? Could it be 3 people that share that element of workload, that actually have 3 brains and 3 different ways of thinking coming to drive a program through? We're looking at that now in terms of the fractional appointments we have to have in the school. That is happening all over the world. I just come back from the IDR meeting, the International Association for Dental Research meeting in Bogota, talking to a number of my long-standing colleagues and friends in the UK and in the US, and we're not alone with the challenges we see at an academic level in the public health system. It's globally pervasive. So we're all trying to think of all the different solutions to the same problem. And how do you actually get one job into 3 or 4 different people? There's nothing wrong with that. But we've got to change how we think.
Absolutely.
And the structures we have in place.
It's interesting, we were talking at the CEO forum yesterday in relation to the enterprise bargaining agreements that we have around the state, which totally inhibit any sort of flexibility or what have you. And it's how do we actually move past that to a different space that enables us to actually have these fractional appointments? They might be employed by one of us but work in 3 different areas, or those sorts of things, which I think people don't want 3 different employees paying them into 3 different bank accounts with 3 different superannuation funds and all those weird things that happen when you try and make fractional appointments. And I get 4 weeks holiday here and 6 weeks holiday over there. How do we actually make that simple for people?
And the conjoint, I think, if we look at our state and the inequity of access to care, conjoint positions between school and DHSV or school and one of the clinics, I think becomes really important, because there's an element of working with the hub and spoke model that you're building, and I've obviously had a long conversation with you around that, and actually our reach as a school, and also in collaboration with our colleagues at La Trobe as well. We shouldn't be doing things in isolation. But the systems we have at the moment inhibit us having a really simple conjoint position.
Exactly.
And the honour isn't the best way of doing it. You want to have a foot in 2 camps at least.
You want them to have skin in the game.
Absolutely.
Yeah. I mean, an honorary position's fine, but that you don't really have a lot of skin in the game with that.
Absolutely agree with you.
So I think it is we might have to do a few things under the radar and not tell anyone, I suspect, to make that actually happen.
But I think if a couple of successes, there'll be a momentum shift with it.
Yeah.
But it is very different thinking.
Yeah. Which I don't, it's interesting talking to my CEO colleagues. I think people are at a point now where, we want to do something. It's not working, so how do we do something different, and what do we need to do to make that happen?
I agree. And I think one of the things I've just taken on the role of the chair of the Australasian Council of Dental Schools, ACODS. One of the things I want to do there is actually bring the dental directorate colleagues more into those discussions, rather than just being the issues that challenge all of us as heads of schools or heads of departments in clinical schools. We've got other opportunities here. We're getting us all together with some very specific questions or problems to try and solve. I think can help us all across not just this state but across the country. So we don't work in isolation. We do actually come together a lot more.
I think that's important, and it's that longer term thinking around, so what do we actually want this to look like in the future? So therefore, what are all the things that we need to set up to make that, or to enable that to happen as we move forward? I think is the important part of it.
I have a timeline. I know I know I'm driving a significant amount of change in the school with a clear vision of excellence, that's the bottom line, but you can't sometimes put these changes through in 20 minutes or 2 years. It's an iterative process, could be 2 to 5 to 8 years, but if we keep moving forward, we start seeing the benefit of the change, then the benefit, people that benefit are our patients at the end of the day.
Absolutely, absolutely. So in saying that, what is, what's the next big thing in oral health research? What are we, we're going to find a new drug that stops us all from getting decay, or are we going to find, we're going to find a new type of mouthwash that stops us all from getting gum disease? Like, is there?
There's a lot going on.
Yeah.
If we look at just at the Melbourne Dental School, obviously Eric and his group with the PG Vax is making significant strides. There's a great example there of commercialisation of an idea in research. We already have had Recaldent and the tooth mousse. We've got work going on looking at an oral cancer vaccine. My own area is nanoparticles and to disrupt biofilms and to get into root canals. Just today I saw in Nature Comms from a group in North Carolina, which is one of our Dental Alliance partners, they discovered a different bacteria that works hand in glove with strep mutans that they think almost turbocharges strep mutans to actually ensure decay happens and we have caries. And if you can disrupt that relationship, you might be able to break down the problem of caries. So it's everywhere. And then we haven't even spoken about lots of I saw last week on dental materials. Our dental materials colleagues love functional materials. We called them smart materials years ago. They're now functional materials. And there's a lot in that sphere of how do you actually deliver not just fluoride through potential bioglasses, but antimicrobial agents or proteins that will drive repair. And then for me, the biggest challenge is around peri-implantitis. How do you understand what that problem is? And they're probably the biggest areas at the moment. But I think you've got all this happening across the world in some outstanding labs. We're connecting some together through Dental Alliance and through our strategic partners. But ultimately, I still think we need a patient to tell us what they want, what do they need. Because I've worked hand in glove with patients, clinicians all my career, and I have a great idea. And my colleagues, my clinical colleague Chris Lynch would always say, nah, we want to go this way. And that's, I think, what scientists need. But the patient will also give you a lot of insight into what their problem is, how they feel.
What's the outcome?
What's the outcome? What are they looking for? And so I think we do have novel drugs, novel vaccines, and novel materials. And they will probably ultimately drive the next change in clinical practice.
Fantastic. I look forward to seeing how that plays out for us here at DHSV and in Victoria.
Well, hopefully a key partner to all of it.
Definitely. Thank you, Alastair, for your time. It was lovely to talk to you. And as I said, I look forward to our ongoing partnership as we move this ship forward.
It's been a pleasure, great talk, and likewise look forward to continuing our working relationship together.
Excellent. Thank you.
You're welcome.